Thank you very much. It's a delight to be here with you to discuss the Find One study and the impact and the importance of patients participating in clinical trials. So, thank you very much. So, today I will be discussing the Find One study, which is a study that involves patients with type 1 diabetes. So, the title is Advancing Therapeutic Options for Patients Living with Type 1 Diabetes and Chronic Kidney Disease. So these are my disclosures. So important for this talk is that I am a Find One investigator and that Bayer is sponsoring this talk. So here's the outline. I will be discussing the basics of chronic kidney disease, and I'm sure most of you know it, but we may have members in the audience that are not familiar with chronic kidney disease. Then I'm going to discuss type 1 diabetes and the stages of type 1 diabetes, and then what have been the therapeutic challenges in type 1 and in patients with chronic kidney disease. And the last item I will discuss is the Find One study. So, what is diabetes? So diabetes is diagnosed in multiple ways. These are the 4 ways that it could be diagnosed. For some, it's just checking an A1C. If it's more than 6.5, you met the criteria. It could be diagnosed by fasting blood glucose of more than 126, or you could have a 2-hour oral glucose tolerance test. That is another way. Or if you have classic symptoms, and high blood sugars, usually above 200, then that would make the diagnosis. So how do we diagnose type 1? So there's different types of diabetes. Type 1 and type 2 are the most common. Type 1 diabetes is suspected when it's an autoimmune disease. So the first thing that people get tested is the autoantibodies. And I listed here on the right 4 of the most common autoantibodies that are tested. So if any of those are positive, you have a type 1 diabetes. Sometimes, depending on age, those antibodies are no longer detected. So if you're less than 35, they usually look for other causes of sort of diabetes, and they measure something called the C-peptide. And if it's elevated, then you could have type 2. If it's low, then you definitely have type 1. If you're more than 35, it's again testing C-peptide, etc., but you could have type 2 if the C-peptide is elevated. So that's how we diagnose type 1. And it's estimated that about 1.4 million Americans have type 1 diabetes. So here's how we classify. There is multiple stages, and then there's the stage where you're asymptomatic. That's stage 1 and stage 2. In stage 1, only the autoimmunity is positive, but your sugar control is fine. So there's no alteration in sugar control. In stage 2, the autoimmunity is positive. So those autoantibodies are positive, but if they test you, your sugar will be altered. But again, you're asymptomatic, you don't know about it. And in stage 3, you're already symptomatic, you have the autoantibodies, and you have the sugar alterations. Chronic kidney disease, as you know, it's very common among US adults. It's estimated that 1 in 7, or about 15% of the US population, that's where you get the 37 million Americans, are estimated to have chronic kidney disease. Unfortunately, 9 out of 10 do not know that they have chronic kidney disease, because similar to diabetes, the early stages are completely asymptomatic. Again, this is very important. That's why it's so important to screen if you're at risk. Chronic kidney disease is very important to diagnose because it is among the diseases that is growing in the predictor years of life lost. So here's an estimate from this journal about years of life lost between 2016 and 2040. You can see that chronic kidney disease is one of those diseases where the years of life are lost. But it's also very important to note that heart disease is also very high, and our patients are at high risk of heart disease too. So if you add all of those, the predicted years of life lost is quite high. So how do we screen and diagnose chronic kidney disease? It's very easy. If you have type 1 diabetes, it's estimated that you should wait 5 years to start an annual check of your for chronic kidney disease. And for type 2, it's at the time of diagnosis. And some of you may wonder why, but that's because type 1, we usually know exactly when you were early on when you had the disease, because those patients usually require insulin, and patients with type 2 can have a more insidious, longer process. So when they're diagnosed, in general, it's estimated that they've had diabetes for about 5 to 10 years before they're diagnosed. So that's why when somebody's diagnosed with type 2, we screen already for chronic kidney disease. And how do we do that? The important thing is to test both the blood test and the urine test. The urine is used to measure albumin in the urine, which is something that leaks from the filters, and we can measure it in the urine. And then the blood test is to measure creatinine, which helps us plug it into a formula with your gender and your age, and it tells us what your kidney function is. So it's quite important to know that if you have albumin in the urine greater than 30, or if your GFR is less than 60, you have chronic kidney disease. The definition of chronic kidney disease is what is here, is an abnormality of kidney function or structure that is present more than 3 months. We all know that sometimes people develop acute kidney injury due to a disease or a medication, etc. If they recover, then they had acute kidney injury. But for chronic kidney disease, you have to have that high albuminuria or that low GFR for more than 3 months. And here you can see in what we call the heat map, depending on your level, so the lower your level of kidney function and the higher the albumin in the urine, the more at risk you are of kidney failure. So here you can see the red is very high risk, orange is high risk, and a yellow would be moderate risk. So why do we care about both GFR and albuminuria? So we care because it's associated with all kinds of things that are not good. So one of them is all-cause mortality and cardiovascular mortality. So in the left two slides, you will see that cardiovascular mortality increases as your GFR decreases. And same thing with all-cause mortality. So GFR below 60 is associated with an increased risk of both all-cause mortality and cardiovascular mortality. But very important too is that in levels below 30, that's also associated with increased risk of cardiovascular mortality and all-cause mortality. So you can see that the higher the albuminuria, the more increased risk there is. Here you can see that the prevalence of diabetes in patients with chronic kidney disease is increasing over time. Here are different time periods, blue, red, gray, and the latest time period is in green. And you can see that for any cause of kidney disease, it's going up, particularly in the early stages. And then it's less often in the lower stages, but it's not necessarily a good thing. It just means that our patients with diabetes are likely dying even before they reach kidney failure. So here we're going back to type 1, and you can see that in this study, they estimated the growth of type 1 patients based on an incidence study that they were doing, and they estimated what it would look like for 2060. And you can see that the majority of the growth during that time period will be in Hispanics and non-Hispanic Blacks. And you can see that more or less there is growth in the non-Hispanic whites, but it's not as dramatic as it is for Hispanics and non-Hispanic Blacks. So here, unfortunately, there's not an exact prevalence registry for patients with type 1 diabetes, but this is an estimate based on NHANES data of how the percentage of people with type 1 diabetes and chronic kidney disease in the US. And it's estimated that 60% of the patients with type 1 diabetes and chronic kidney disease are white, and about 18% are Black, and Mexican American about 2%, and other Hispanic 7%, for a total for Hispanic of 9%. It's estimated that they have a GFR of 57. That's about a stage 3. And then the protein in the urine on average is 89. And remember, we discussed that more than 30 is considered abnormal. So in general, they have a high levels. And so here is another study in type 1 patients where being of African Caribbean ethnicity is a predictor of who's going to progress to chronic kidney disease. So you can see that the sort of yellowish mustard color is the African Caribbean individuals, and the sort of gray color is the African Caribbean. And you can see that the individuals in the mustard color uh, are at higher risk. Again, it takes years to develop chronic kidney disease, so that's why we see the difference. After, let's say, year 8, you can see really increasing the hazard ratio of chronic kidney disease. So unfortunately, there's not a lot that has been tested for individuals with type 1 diabetes and at risk for chronic kidney disease. So you may remember the DCCT EDIC trial that's from the mid 2010s or so, where they were able to prove that intensive glycemic control, so that means that your A1C was less than 7, was associated with improved microvascular. Those are retinopathy and kidney disease, so less complications. And then in the late 1993, we had the captopril study. So those were the two studies that have shown a positivity for treatment of kidney function in patients with type 1 diabetes. But these are very old studies. Here we see that even though A1C is so important for the management of chronic kidney disease, unfortunately, Hispanics and African Americans are more likely to have uncontrolled A1C. And you may wonder why that is. So that's in part because they're usually less likely to have technology. They're more likely to have insurance that does not cover the pump, etc. They are more likely, because of this, is they end up in the emergency room more often and more likely to have more admissions. So all of those things affect who will develop chronic kidney disease. Of course, if we know that glycemic control is so important, Hispanics and African Americans are less likely to have access to this tools to control their blood sugar, then they're also at increased risk for chronic kidney disease. So here are the guidelines for the diabetes management in chronic kidney disease. This was a consensus from both the American Diabetes Association and the Kidney Disease Improving Global Outcomes, or KDIGO. And you can see that the items in blue are for both patients with type 1 and type 2 diabetes. And the new medications that we all have heard of, the SGLT2s, the GLP-1s, and finerenone, that have shown kidney benefit, are in green, but none of those have been approved for patients with type 1 diabetes. So even though they've been shown that they're effective for type 2 patients, the studies on type 1 patients have not been done. So today I'm going to talk about finerenone, which is a mineralocorticoid receptor antagonist. And so first I was going to discuss how mineralocorticoid receptors affect the brain, blood vessels, the heart, and the kidney. So in the kidney, they produce aldosterone, decreases potassium, and may be a component or an important factor of driving proteinuria and glomerular injury and causing vasoconstriction. In the heart, they produce scarring in the kidney known as fibrosis and damage of the blood vessels, causing what we call inflammation of the blood vessels, and they activate the sympathetic nervous system. All of that leads to increased hypertension. If aldosterone is high, it increases heart failure. And again, all that scarring in the kidney also leads to chronic kidney disease. So as we discussed, our patients more frequently have diabetes, heart disease, chronic kidney disease, heart failure. That's usually combination, unfortunately, that our patients commonly have. And that in part is secondary to the overactivation of this mineralocorticoid receptor antagonist. And I already explained sort of the inflammation, the oxidative stress, the damage of the blood vessels leads to more damage in the kidney. So in patients with type 2 diabetes, this is a type 2 diabetes study, finerenone decreased kidney failure and death from kidney disease. So in this study, there was a composite primary outcome, and composite means that they took many of the outcomes and just combined them. So here, the outcome was kidney failure, so anybody that went on dialysis or got transplant, but they also looked at a decrease in the kidney function, as we know the GFR, that was at least 40%, or death from a renal cause. And so that was the primary composite outcome. And patients that were on finerenone and had type 2 diabetes and were on a RAS blockade, so they had to be on ACE inhibitors or ARB, they had an 18% reduction in kidney failure, or the kidney composite outcome, compared to those individuals that were on placebo. So placebo is the sort of the inactive medication. So those that were on finerenone did better. And again, I want to highlight that, yes, type 1 patients are not exactly the same as type 2 patients. Type 1 patients tend to be younger, so that's why the effects of aging are mostly seen in patients with type 2. And patients with type 2 also tend to have dyslipidemia and more insulin resistance than patients with type 1 diabetes. So that's why, even though they're similar and under the microscope sometimes they look similar, the patients may not be the same. So that's why it's important to do the studies in type 1 patients to see if the medication really works for type 1 patients, because we cannot say, oh, just because it worked for type 2, it's going to work for type 1. So that leads us to the FIND1 study. And these are all the countries. It's a global study. We estimate that about 20% of the patients will be from the United States. And you'll see there listed are all the countries that are participating in the study. So in the United States, you can see here all the points, all the sites, and there are more being recruited. But you can see all the sites where there are clinical sites where they're recruiting patients for this study. And we, as a study, are very interested in recruiting would like about 30% of patients to be from Hispanics or African Americans, because we want to make sure that it represents the US population. So this is a scheme of what the trial looks like. There's a 14-day window for screening, and that's when they look at, is your sugar under control? Is your GFR low? Did you have albumin in the urine? So that you meet the criteria for the study. Are you an adult, etc. And then people are going to be randomized to finerenone 10 or 20 based on their GFR, or the matching placebo, which, as I said, is the inactive medication. Patients, the study is only for 6 months. Because there's so much data on type 2, this study is only 6 months, just to make sure that the benefits that we're seeing early on for the patients is also seen in patients with type 1 diabetes. So these are the inclusion criteria. So obviously patients have to be adults, so more than 18. You have to have type 1 diabetes because it's a type 1 study. By definition, they want to be, these are patients that started insulin within 1 year of diagnosis. Your sugar control should be adequate, so less than 10%. Your A1C needs to be less than 10%. And then obviously you have to have chronic kidney disease. So you have to either have a GFR of 25 to 90. And in this study, they're looking for patients that have albuminuria greater than 200, but less than 5,000. And that is because the endpoint is changes in albuminuria. So they would like to have individuals that are higher risk. The potassium has expected potassium is less than 4.8, and to be on a stable ACE inhibitor or ARB, because ACE inhibitors and ARB are the standard of care for diabetic kidney disease. So, why is it important that we talk about who participates in clinical trials today? And that is because most of the US trials in clinicaltrials.gov do not report race or ethnicity. We are not able to know who's participating in those clinical trials. But when they looked at it, it looks at 43% reported results. They did not have any race or ethnicity data. So we don't know who those patients are that participated. So we want, for chronic kidney disease, for example, Hispanics and African Americans are overrepresented in the individuals that get the disease. So it would be very important to make sure that the patients that have the disease or at a higher risk for kidney failure, that they also participate in the studies. Um, so even though the certain diseases are overrepresented by certain groups, sometimes in the clinical trials they do not look like reality. So on average, most of the patients, almost 80% of all clinical individuals that participate in clinical trials are white. 10% are black, 6% are Hispanic, and 1% are Asians. This is all clinical trials. And here I give you an example of the COVID-19. So COVID-19, as you all know, the rate of hospitalization for blacks and Hispanics was almost 3 to 4 times that of white people. And the rate of death for blacks and Hispanics was also higher than for white people. But you can see here that when it came to who participated in clinical trials, and in this study, they looked at Boston, New York, and Minneapolis. And you can see that even though I'm going to show you sort of the clearer numbers. I don't know if you see Boston. So the lighter, I don't know what color that is, purple, let's say, where it says 38%, those are the individual cases for Black individuals in Boston. But unfortunately, when they went to do the clinical trials, only 23% of the population was Black in the, let's say, Boston studies. And in Minneapolis, it was even more dramatic. 33% of the individuals um, had a COVID, but only 5% of the clinical trials in Minneapolis had individuals that were Black. Um, and you can see differences in the other way too here. Hispanics for both Boston and Minneapolis were below what they should have been recruited, but then in New York, they made up 51% of the clinical trials compared to they made up 33% of the cases. So it can go both ways. So why is the representation so important? It is important because there is a principle of justice when we do clinical trials. We want to make sure that the people that are affected by the disease get the benefit from whatever medication is being studied. And also, it may affect the science too, because we may say, oh, this drug works really well, and then when you go try it in clinical care, it ends up that the effectiveness is way lower because for whatever reason it works differently for different groups. So we want to make sure that. And then there's another thing that's very important, or any aspect that's very important, that I think it negatively affects the trust of society if research does not represent the people that have the disease. So if we don't participate in trials, it may contribute to health inequities. And so as organizations and researchers, we work really hard to ensure that the participants in clinical trials represent the demographic and the socioeconomic background of individuals with the condition. So this is just to reiterate that diverse clinical trials provide the opportunity to ensure drug efficacy for patients everywhere. So in conclusion, chronic kidney disease is very common. It is more common in non-white individuals, and non-white individuals are more likely to end up in kidney failure. Lack of trials for patients with type 1 diabetes and chronic kidney disease are of concern. Now we have a medication that is oral that has been shown to be beneficial for patients with type 2 diabetes. And now we're trying to make sure that it also works for patients with type 1 diabetes. Successful recruitment is a team effort. It's as you saw from the presentation from Paul Conway, it's very important that not only that the physicians are involved, the nurses are involved, and the whole community is involved in recruiting for clinical trials. Thank you very much for your attention.
Thank you very much, Dr. Rosa. And I tell you what, your reputation for caring for people and the individual is key. And I think as we're talking about type 1 and type 2 diabetes, understanding that type 1 patients in type 1 trials have been actually limited, in the solutions for type 1 patients have been limited. And what we're trying to do here is change that dynamic. I was wondering if you could tell us, based on your work at the Joslin Center, to, for the people that are watching this and that may not be familiar with a type 1 patient, if it occurs at a younger age, what types of people are we talking about? What types of things are they involved in? What's going on with their life? Put a face on a type 1 patient for us.
Yes. So that's why I say that it's very important to look for those autoantibodies, because unfortunately we're seeing a growth of type 2 diabetes in children. Particularly Hispanic and African Americans are also getting type 2 diabetes at a younger age. So that's why testing for the autoantibodies, it's not like before. We used to say, oh, if they're young, they probably all have type 1. Nowadays, you can't just say that. You really have to test for the autoantibodies. Because the treatment is different. If you have type 1, you really need insulin right away. If you have type 2, you can use other medications. So it's very important to make the correct diagnosis.
Okay. And then as we're working towards the goal of getting a higher recruitment level, you've talked about this in terms of the medical community and working with patient advocates. But are there other groups that are out there in society that we should look at as advocates and as medical professionals to raise awareness of this trial, and that patient advocates that are watching across the country, our ambassadors, NKF ambassadors, could be reaching out to educate and ask them to talk about this? I'm thinking of things like the faith community, other communities, the business community. What types of things have you seen that work well in Boston and other places?
Sure. To be honest, for clinical trials, our best ambassador are the patients. The patients, as you noted, that have participated in trials, they're great ambassadors because they know about the care. And when you participate in a clinical trial, it's very important to, as you noted, to know the risks and benefits. In a study like Find One, this is an FDA approved medication that works for type 2. So the risk benefit ratio for somebody that is, let's say, more risk averse, this might be the right study for them. Some patients want to participate in trials that are more risky. So let's say it's medication that is not FDA approved, but that's not for everybody. And so we do, as you noted, we do tend to ask all our patients to participate in a clinical trial, and we get a lot of no's, but we get some yeses, and so that's how we are able to recruit for our trials. But it
I know
does.
that.
I'm
Go
sorry.
right ahead.
That when you participate in clinical trials, it does represent a certain commitment from the patient, because they do have to travel sometimes once a month or sometimes twice a month to come to the center. And there's always blood and urine to be given because we want to make sure that they're safe. So for some patients that they are not willing to do that, or unable, or lack of transportation, etc. But that's why pharma and the investigators provide some, let's say, transportation reimbursement, or are able to make accommodations for time. So we see patients sometimes as early as 7 p.m. so that they can do the clinical visit and then go to work, because we don't want to affect their lives so much.
Yeah, and I know you're very passionate about involving people. So one of the things I wanted to ask you about is this: in terms of national policy, national bipartisan policy over the past 5 years has been really focused on trying to take care upstream and prevent suffering. With the advent and with the start of this trial, how has it been as a medical professional to be able to say for a population that has been left out of that conversation? With some of our diabetes patients. How has it made you feel as a professional to know that we're actually able to extend that promise of taking care further upstream if we can get more folks into this trial and see how we do in trying to show the efficacy?
Sure. So I'll answer your question in two ways. One, I feel very strongly that in the US, there should be a screening indication for all patients at risk for chronic kidney disease. Right now, the US Preventive Service Task Force is looking into giving a screening indication. And I believe that everybody that's at risk, that means anybody with hypertension, anybody with diabetes, anybody with obesity, anybody with heart disease, anybody with a family history of kidney disease, they should be tested. I think for me, that's the most important, because we can have the most wonderful medications, but if you do not know that you have kidney disease, you will never be treated. And so, therefore, that's the very first step. I do believe that patients with kidney disease have been left behind from clinical trials because our patients, have other complex diseases. They got kidney disease because they got diabetes, or they got kidney disease because they had hypertension or had other disease. So they tend to have to be more complex. And I think that industry was shying away from looking into this area. But I think or I hope that is over, because we have seen the tremendous amount of positive trials in kidney disease, because now they're doing the trials. So that's why I think there's tremendous hope for patients with kidney disease. Then hopefully that in the future, or I feel that we're there now, that we are working towards preserving kidney function, and we're not working towards making kidney failure treatments. I think we're working towards preserving their own kidney function so that our patients will live with their own kidneys and do not need dialysis and transplant. That is my hope for the future. Sure. Um, sure. Now we know that 9 out of 10 people with kidney disease don't know they have kidney disease. And what is important is that once they know they have kidney disease, they're more likely to be treated. They're more likely to have a diagnosis in their chart, and people are more likely to take care of their kidneys. When you have kidney disease, some of the medications need to be dosed differently. You're at greater risk of acute kidney injury, so you have to be more hydrated, for example, when you have a procedure, etc. You have to be, you have to treat those kidneys with tender loving care. So knowing the diagnosis is very important. And now, as I mentioned and you saw, there's at least 3 or 4 new medications that, at least for treatment of diabetes, are indicated. And patients should ask for them, because we want them to live with their own kidneys for years and years to come. Yeah. So, for example, right now, I'll give you an example. Those glucose continuous glucose monitoring, they have been shown to help patients maintain their A1C at a better control. And as I mentioned, good A1C control prevents kidney damage. Unfortunately, it's not available for everybody because some insurance cover it, some don't, some have restrictions, some don't. So it depends. You cannot even fathom that, depending on your insurance, you will get a different treatment, even though the treatment is indicated. And and so for me, that is a struggle, and we do try to help patients um, get the medicine that they need, but sometimes it is hard.